Hi there. I am waiting for Dr. Jordan Robertson. Let's see. You know me, I'm always thinking that technology is not going to work. Um, but I know everybody's really excited to talk to. She's amazing. I just want to say she is amazing, and I'm really looking forward to having her on. So I'm just going to wait till I see her come on here. Come on. We're going to be talking about endometriosis, pelvic pain, period pain. Um, And I loved seeing all the questions that came through. I thought they were amazing. And let's just wait till I see her. It's always like a little cagey here at the beginning because I'm like waiting to see, come on, Dr. Jordan. Waiting for that Dr. Jordan to sign on. I know she's here, so I just or request access. Hopefully she'll request access. So anyway, I feel like we haven't really talked about pelvic pain in a while, and the kind of pelvic pain that I do is quite different. I do vaginismus, vulvodynia, vestibulodynia. I don't really do endometriosis. We don't really do endometriosis on our center, so it's really cool to have an opportunity to talk to Dr. Jordan. But who I'm hoping is coming on soon. Aha, here we go. Gotcha. Dr. Jordan, let's invite you on. Hopefully she'll be on any minute. First of all, she's the funniest. I have to say, I found her because she was so freaking funny. Um, there
Hi,
she is.
we did
Hi.
it.
I know. It's always like magical when I actually pull it off. I feel like, am I actually going to be able to do this? This is like amazing. Let me just adjust the screen a little bit. Anyway, thank you so much for coming. I was just saying to everybody that I have been stalking you. I basically have been stalking Dr. Jordan. Do you go usually by Dr. Jordan? What do you go
I
by?
just go by Jordan is
Okay, I just go
perfect.
by her
Jordan is
Sheva.
perfect. Yeah.
Perfect. Okay. So I just started saying that when I first noticed you, it was because your posts were so freaking funny. And like, there's very few posts that I actually read to my husband, but like yesterday I was cracking up. What did it say? It said, well, it was a couple of days ago. It was, it takes about 5 days. Oh my God, I'm not going to get it right. About from the
The
weekend.
first 5 days after the weekend. The first 5 days after the weekend are the hardest.
I love that. I love that. Like, when do you even think of these things? You know, it's amazing. Anyway, it's amazing. So thank you for being
Thanks.
here. Thank you for being here. And I want to talk about pelvic pain, and I hope you saw we got a lot of questions. Um,
Mm-hmm.
Before we do that, though, can you just talk a little bit about being a naturopathic doctor? Because I feel like in the United States, we don't really get that. And I know you're like an OBGYN, and I just talk to us about it because I think it's amazing.
Sure. So yeah, like naturopathic doctors, it depends on where you live. We're all regulated by state, and really like that, depending on where you live, the type of qualifications and schooling and whatnot that someone needs to be called a naturopathic doctor is going to vary significantly. So in Ontario there are separate schools for naturopathic doctors, so separate than conventional medical schools. We are regulated at the provincial level. I myself have a prescribing license in Ontario, which means that I can prescribe bioidentical hormones like estrogen, progesterone, and thyroid. But that's just based in Ontario, right? So my scope of practice is different than, say, naturopathic doctors that practice in Quebec, right? Even right next door to us, the regulations are very different and their scope of practice ends up being really different. So where my sort of background is a bit unique is that my background is actually in sort of critical appraisal, we call it, which is where reading medical research and trying to decide what's true or not, and then how that influences clinical practice. So to go into, alternative medicine seems a little bit ironic, right? That why, if I'd spent so much time in my undergrad studying, science, why would I go into what was maybe considered not mainstream medicine? But for women's health specifically, the evidence for an integrative approach to their healthcare is actually really excellent. And that's what sort of drove me into that area of research. That's why I've spent so much time on endometriosis, because the support that we can offer women who have dysmenorrhea or menstrual cramps or pelvic pain or endometriosis is very good, meaning that we should be offering women this sort of like more integrative approach to their care versus conventional only, or only offering solutions like the birth control pill, which for many women, that's counter to their fertility goals, right? So that's how I sort of landed myself in that position. So I'm not an obstetrician, which in Ontario and Canada that would require a different track of education.
Can you
But
do like internal exams?
we can do internal exams. Yeah, so that is within our scope in Ontario. Um, yeah, so that is something that we can do.
You basically function as an OBGYN for all intents and purposes, even not exactly. I shouldn't say that like
No,
that.
you shouldn't say that. No, not
Okay,
exactly.
I'm
Yeah,
sorry.
our
She
scope
doesn't
is super
function like
different.
an
No, that's okay.
OBGYN.
Our scope is really different, right? So, like, my prescribing scope is really narrow in Ontario, meaning that we only have a few drugs that are available to us, but we have the ability to run lab work. So, specifically, when we're starting to talk about things like endometriosis, like the where women struggle often is in that assessment phase, right? Where women, our time to diagnosis, meaning how long it takes for us to even offer women appropriate assessment, can be 8 to 12 years for their endometriosis, where we can fast track a lot of that if we are offering them the kind of assessment that we can do, meaning things like running blood work and whatnot. So it's slightly different, like in terms of what our scope is. But we deal way better with some of those chronic pain syndromes, right? Because it's not, we have the time and the ability to spend chatting with women about all those aspects like diet, lifestyle, and whatnot that will influence their monthly pain.
So, but right before we go down the rabbit hole of endometriosis, because I feel like once we start talking specifics, which I really want to do, it's going to be a rabbit hole. We're going to talk about it. Can you just talk a little about your podcast? Because I feel like it's great. Like, Dr. Jordan has an amazing podcast, which I think is about educating women, allowing them to make their own decisions. And that's so much what I talk about. And so I feel so strongly about it. And it's a great podcast. But just to spend a minute talking about your podcast.
Sure. Yeah. So the goal for it for me, like coming from a background of more like critical appraisal and medical research, it frustrates me that that information is not accessible to the public, right? Where, things are being published on the daily. The amount of time it takes for published literature to make it to public health is so long that women often aren't benefiting from how quickly things evolve and change in medicine. So for example, it took us years to change our guidelines around vitamin D, even though we knew it, right? Like deeply in the literature, we knew that it was an issue. It took so long for the government to get on board to make their recommendations that I want women to have access to.
Why don't you say what they are, just so once you're hitting vitamin D?
Sure.
There.
Yeah. So when we're talking about things like pelvic pain and endometriosis and fertility, our guidelines for vitamin D need to be better than the current reference ranges, meaning that we want women to sit in the sort of like 100, 120 nanomoles per liter blood work, whereas we find it acceptable for women to be anything over 70 or 75, depending on where you
Well, we
live.
have 50 and
Yours
that's
is
crazy.
50. Yeah,
Yeah,
yours is the bar's even lower.
exactly.
But in the research, we know it needs to be higher than that. But for public policy to change around health takes years, right?
Well, that's
Whereas
like estrogen. Estrogen is an example where we're lagging. Information is so lagging, right?
exactly, where women can access that information. And so I wanted to create a platform where we could talk about these current concepts in women's health, where we could bring sort of that evidence basis to the mainstream media for women to be able to access. Because the other challenge is because women are dying for information about their health concerns, they end up reading about it on Dr. Google, right? Or on websites that are not in their best interest, that are not actually evidence-based. And so I wanted to create this very accessible way for women to get information about their health that sort of bridged those two things, right? It let them have something that was easy to listen to, that was very educational, but also brought like the more up-to-date research about women's health to mainstream so that it was more accessible to them. And it wasn't this thing that like only doctors knew and that wasn't something that was available for them.
Right. So I think it's a great podcast, and I highly, highly recommend that people check it out. So just throwing that out there. Okay, now let's talk about, why don't you tell me what endometriosis is? I was just saying before you got on that we do lots of pelvic pain. We don't touch endometriosis in our center. Like we refer out. It's a very different kind of pain than vaginismus, vulvodynia, vestibulodynia, which is really where that's the stuff I know. Low hormones, low desire, low arousal. Endometriosis is just, to me, it's just the other side of the other side of the valley. So Why don't you describe what endometriosis is and sort of introduce people to it?
Sure. Um, it's funny, like my like undergraduate immunology thesis was on endometriosis, which was
Really?
probably 60 years ago at this point. But
I just want
actually,
to say my thesis was on vibrator use by women. I definitely win this one.
you totally, yours was way cooler than mine. Um, so even like 20 years ago, or however many years ago it was, we were starting to understand that endometriosis is actually more of an immunological condition versus a hormonal condition. So often when women read about it, they read that endometriosis, which is growth of that endometrial lining. So every month we grow that endometrial lining that then is shed with the menstrual cycle. And in women with endometriosis, that endometrial lining gets misplaced, meaning that it ends up outside the uterine cavity. It ends up in the pelvic cavity often. And so, what we think that happens is that it actually travels up the fallopian tubes and escapes the uterus into the pelvic cavity. Although we've never witnessed that happening, like we can't watch that happen, we just think that's what happens. Um, and those satellite lesions actually implant in the pelvic cavity and actually respond to our hormones just the same as our uterine lining responds to hormones, which means it grows, it bleeds, it sheds, but it's not where it is supposed to be. And so you can imagine if you have a period that's happening outside of your uterine cavity, that's going to create a lot of havoc as far as pain and discomfort for those women. So that's actually what ends up happening in endometriosis, is that these satellite lesions end up outside the uterus, but they grow and respond to hormone fluctuation every month.
So let me ask a question, and just remember I'm a PhD, not an MD, so it may sound like a stupid question, but when your uterine lining builds up with blood, which is internal to your uterus, right? I always assumed it was in that cavity, but that the idea that tissue outside the blood could kind of live on the tissue, like where does it sit? Like why does you know what I mean? Is it actually in the tissue, the blood? Is that what happens?
So the best way to describe it is actually that it's very cancer-like. These lesions are very cancer-like, meaning that those cells, so those endometrial cells, end up where they're not supposed to be. They end up adhering to the pelvic cavity or other places. It can be on the bowel wall, like the outside of the bowel wall. It can be on the mesentery. It can be on the outside of the bladder, which is why women end up with so much complex pain when it comes to endometriosis, right? So those satellite lesions end up outside the uterine cavity and they grow and they, saying that it's a period is really a way, sort of a layman's way of explaining what's happening there. But essentially, the process that those cells go through with each month draws a lot of attention from our immune system, and that's actually what triggers a lot of the pain and a lot of the issues. So in women without endometriosis, if a stray cell ends up where it's not supposed to be, the immune system has no problem identifying the issue and eating the cell, right? And just like your white blood cells would identify a bacteria or a cell that's been damaged or has had a mutation, your immune system in theory should deal with those issues. But in women with endometriosis, they have some underlying challenges in their immune system that allows those cells to live outside the uterine cavity. And it's the interaction between those satellite lesions and your immune system that starts to create all of the pain and the symptoms that women experience. And that's why typically the symptoms are experienced around the menstrual cycle, because it's responding to hormones just the same way uterine lining would respond to those hormones, and that's what sort of creates or propagates the inflammation.
So it's like an autoimmune reaction.
Kind of. So yeah,
Sort of.
their
Okay.
immune cells are not normal. So if we sample the immune cells in women with endo, they're not typical immune cells. They tend to sort of like contribute to the growth rather than mopping up those cells. And so there is a component of it where there's some dysfunction in the immune system.
So why are the traditional ways of dealing with it the pill, which is hormonal, and then people kept asking about the coil, which is that a Canadian term? Because I look because
I
when
don't
I
know
looked
that
it up,
one.
it's the Mirena. Oh, okay, so that's
Oh,
people.
okay.
It's the
Like an
I
IUD.
looked it up and I was like, what's the coil? But it's the Mirena, so it was IUD. So the typical treatments are IUD and birth control pill or surgery. And
Hmm.
but you're saying it's actually not hormonal. So it's,
Yeah, so hormones don't cause it, right? And I think that's the issue, like that where we sort of misunderstand endo is that the hormones don't cause it, right? Estrogen is not the villain. Estrogen is gasoline on an already burning fire when it comes to endometriosis. And so the reason we use hormonal therapy, and it's not wrong to do that, is that it takes things out at the knees, right? It says, well, if these lesions respond monthly to hormone fluctuations, what happens if we cut that out, right? And the best example would be something like Lupron or some of the GnRH medications that actually literally cause sort of medical menopause. If we stop all of that hormone cascade, we take the endo out at the knees and it can't respond. So often we have, cite that women who have endometriosis, it will get better if they get pregnant, right? So if you get pregnant and you have no menstrual cycle for a year, then will those, maybe those lesions will get better. And it's because if they don't have that monthly ebb and flow of the hormones, they lose the stimulus to grow and cause inflammation. And in some cases, the woman's immune system will actually deal with it. But that's why we use hormonal medication, because the stimulus there for them to grow and be and are impacted basically monthly by those hormones. So it's not getting at the root of the issue, but it's the most practical way of solving the issue is if we cut out the stimulus, which is estrogen.
so I feel like you're hitting exactly on what happens with women's health quite often. Like we deal with the symptoms, but not necessarily the problem.
Yes.
So why don't you talk to what you think might actually solve the problem?
Well, it's hard to know because we know genetically that there's some differences in women who have endo than women who don't, right? And so when we look at it from that perspective, there may be women who are, and I don't want to use the word destined to have endo, but who are wired to struggle more. Predisposed, way better word. Yeah.
Okay.
Who are predisposed to having endometriosis. I mean, like most genetic conditions, we probably think there's multiple hits there that are causing you to sort of tip over into being actually truly afflicted by the condition, meaning just because it's in your genes doesn't mean it is like destined to happen, right? There's probably other factors.
Is there an age or typically where it starts or life stage?
It typically gets worse as women get older, right? Because of like the length of time that they have had
Older,
those
like
lesions.
23? Older, like
Yeah,
45?
so
Okay.
that's a good question. So like as women age, their incidence of it goes up and it does tend to get worse with time. So some women, it will show up very early on in their menstrual years. And so I always sort of want to educate women, especially young girls. Like the research is that we need to lower our tolerance for menstrual cramps in adolescence, meaning if young girls are missing school because of menstrual cramps that are not well managed from analgesics, they should be screened for endometriosis, right? We need to stop
Everybody hearing this? I want to
normalizing.
make sure people
Yes.
hear this. I want to, especially because there's a bunch of moms. I know there are a bunch of moms
Mm-hmm.
watching. So yes, okay, go. So if
So
your
our
daughter really complains about period pain, like take her seriously.
That's right. So we need to it's called lower our tolerance, meaning that we need to screen earlier than we currently do for adolescents who have severe dysmenorrhea or menstrual pain. Where we often find it is when women land themselves in a fertility setting, right? Which is similar to lots of challenges in women's health, is that we don't go looking for a problem until women try and get pregnant. And then after they've been trying to conceive for 6 to 12 months, we finally start to inquire about their menstrual history. And it turns out they have horrific menstrual periods. And then there's another window of opportunity where we may find it in women only because they've landed themselves in a fertility setting. I do find that older women, sort of like 35 to 45, often by the time they've made it to that point, they've been screened, right? Usually. But at that window of time, the challenges I have is that those women are told to wait for menopause for it to go away. So often the solutions that they're offered at that time are not really compassionate solutions, if I can use that word, because those women are still often like 10 or 15 years away from menopause. And yet we deem that to be sort of the final cure for endometriosis, and often put women on this track of waiting for their hormones to decline, so that their periods will finally get better, which in my opinion is just not an appropriate way to deal with it.
Okay, so what do you do?
So what do we do? That's a good question.
What do you do, Jordan?
So So the observational research on endometriosis, which means if we just watch women who have endometriosis, there's things we know about them. Women tend to have different diets than women who don't, right? So if we just look, and this is observational, meaning it's not like we prescribed them the diet and it treated them. We just watched them to see what happened. So women who have endometriosis eat less fruits and vegetables than women who don't. They eat less fish. They eat less whole grains, less olive oil, less lean protein, which means, on the contrary, they eat more processed food, more cured meats, more saturated fat in their
More
diet,
simple, probably simple carbs, right?
more simple carbs. Yeah. And so that's just observational. And so who knows why that is, right? If that's causal or whatnot, or if those women are medicating their pain with processed food. I don't know, but it's something we notice. And then when we start to look at the research on treating endo, we find that if we give things like antioxidants, if we give things like vitamin C, vitamin E, other antioxidants like melatonin, that we can actually decrease pelvic pain and decrease the amount of analgesics that women will use during their monthly menstrual cycle. So we observe that women who eat more antioxidants do better, but we also know that if we give women more antioxidants, they do better. So it's starting to help us understand that if we treat this from an inflammatory perspective versus a hormonal perspective, we can actually help support women. And one of my treatment goals with women is to downgrade their pain control. So meaning if they're using opioids, can we downgrade to a NSAID? If they're using NSAIDs, can we downgrade to a hot pack, right?
Are there inflammation markers higher than other women?
Yes.
So you can actually blood test this to see, oh,
Mm-hmm.
you have high inflammation. Oh, that's amazing. Okay, that is amazing.
Yes.
Okay.
Yeah. And there's a specific blood marker that you can test to actually try and look for endometriosis too, which this is
Really?
relatively new. Yeah, this is relatively new. So actually, endometriosis lesions will produce the same cancer marker that is made in ovarian cancer. So CA-125, which is typically has been thought of as a marker for ovarian cancer, actually is found in women with endometriosis as well. So it's a great rule-in strategy for women. Some women who have endo don't produce that blood marker, and so it's not a great rule-out strategy. But if women test positive for CA-125, and it's a simple, inexpensive blood test,
See, that's
it can.
incredible, because I was under the impression you actually have to go in and do surgery in order to diagnose.
You do. So that still is technically the gold standard. But because of that, right, like anytime surgery is the diagnosis point, it means that we're underestimating how many women have endo, right? Because in 100 women, how many of them do we look, right?
Correct. Yes.
5. And then the other 40 who have it just live in pain. Whereas this blood biomarker is actually helping us identify women a little bit sooner, and it's helping us triage women who should have laparoscopy. So laparoscopy still ends up being the gold standard, but this blood biomarker can help us identify women who have pelvic pain that we're suspicious that it's endometriosis, and it can help them with their decision making, because lots of women are a bit I was gonna say gun shy, but like knife shy about having laparoscopy.
Well,
But
one of
if
the questions we got is whether the laparoscopy can make things worse.
That's a good question. So generally, laparoscopy improves a woman's symptoms, but it's often temporary, right? So unless we're treating the underlying risk factors or reasons why we think women developed their endo in the first place, just because we take it out doesn't mean we've shifted things like enough that that never becomes a problem again. I would say maybe with the rare exception of my gals in that 35 to 50-year-old age range where they might only be 6 or 8 years away from menopause, because they might actually make it without needing a second surgery, right? If they end up having a surgery late in their life. But typically we see recurrence in women who've had surgery. So it may not make it worse, but it may still return. The challenge with surgery is that it can compromise fertility in some cases, and depending on the extent of it, can cause pretty significant scar tissue, right? Which I'm sure is something that you come across quite a bit, right? As women who've had previous surgeries, like gynecological surgeries, that end up with significant scar tissue that then impacts their quality of life for totally different reasons.
We're seeing the scar tissue in the vagina. So
True.
that's
Yeah.
okay. So that's a little bit, yes. We pretty much go through the vagina and stop there. It's certain.
Okay.
So yeah, so that's so interesting. So basically, when they go in and they cut out some of the scar tissue, it may start work for a while, you're saying, and then it may come back again because if you have a predisposition for it, which is also, again, an argument for that treating the underlying causes of it. So you've mentioned some food, changing diet.
Hmm.
Is there anything else that you guys? You're saying also pick up the vitamins, right? Sounds like pretty
Yeah. So
significant vitamins.
there are some nutrients that, I would say the best data we have is in decreasing painkiller use, which is a good metric, right? If women are using less painkillers, they feel better and their pain is less. And so nutrients that show up, interestingly, are things like melatonin and ginger. The research is pretty significant on both of those for pelvic pain and menstrual cramps, but also endometriosis, which is kind of cool.
It's amazing. It's more than cool because there's such easy, not sort of non-problematic additions to people's diet. It's such a simple way. Like sometimes this drives me crazy, Jordan. I don't know if you have this too. Like when you start coming up with solutions that you're like, why the hell didn't people talk about this sooner? Like you could
Yeah.
use ginger and you could use, I don't know, I'm going to guess turmeric too as anti-inflammatory.
Turmeric is in there. Yep. So some of those other anti-inflammatory herbs also have research for them. So turmeric has some great research and it actually makes it into the pelvic cavity, which is cool. So women who have endometriosis and we give them turmeric by mouth, we can sample their pelvic cavity and the turmeric's in there doing its thing, which is great.
Really?
Um, and other antioxidants and nutrients have been shown to have promise as well. But I will say that we haven't developed that enough in the research, like to my liking. So are they fine and safe? Yes. Do we have absolute certainty around efficacy? No, right?
But they
So
don't really hurt. They can't really hurt.
no, they don't really hurt, with the exception of there is one nutrient, resveratrol, which is the antioxidant that's in red wine or grapes or blueberries, actually is contraindicated to use at the same time as Lupron, which is kind of interesting. So it acts very similarly to Lupron, which is why we use resveratrol for women with endometriosis. There's evidence that it prevents regrowth and it prevents recurrence after surgery, but it actually decreases the effectiveness of Lupron when they're taken together. And so even though they're simple, easy, quote unquote safe nutrients, I still want women to chat with their practitioner about what is the most acceptable for them, because that decision making around do we or don't we use the pill, do we or don't we do surgery, do we or don't we add other nutrients, they can't all always be done at the same time together. So it's important to have that conversation with someone who can help kind of guide you around that.
So here's what I hear that's very frustrating from a lot of my patients. It's very hard to find, at least in the United States, an MD or a doctor like who also is willing to discuss like all of these like natural solutions or diet. Like somehow either it gets poo-pooed or there isn't time, as you brought up. And so I guess, can people access you, or what do you suggest in those situations? Like, are you accessible? No, seriously. Like, I feel
No,
like,
it's a good question.
you
It's a
know,
good question. And I wish I had better answers. So for me, I'm bound to work with women who live in Ontario or who are currently in Ontario. So you don't even have to be a resident of Ontario. You just have to have your 2 feet in Ontario. And in a way, like that's
even
actually a
now with
positive
COVID,
thing.
even now with
Even with
COVID,
COVID. Yep, even
really.
with COVID. I mean, it's in a way that's a positive thing when the practitioner that you're working with has some regulation, right? Because it means that they're accountable. If people have no regulation and they could treat aliens and mice and you, and it doesn't matter where you all live, that raises just my question around like the quality of the individual that you're working with, right? So certainly like the podcast has been a way for me to reach women that are not in Ontario, and we're
I'm
working
just
on
laughing.
some.
I just got a text. So somebody just sent a message saying, I'm in Ontario. Okay,
Oh,
guys,
perfect.
you can see Jordan. Okay,
You
go
can
on.
come. You can come. Um, and we're working on some ways to have more educational content for women, so that they can have some of this, because some of these things are very just like lifestyle-based, education-based things that women just don't know, right? Women don't know that, certain things in their diet are having a negative impact, that certain things in their diet could have a very like simple positive impact if they included it. Often women feel really unsure about the options that have been given to them because they don't see the forest for the trees, right? No one's told them, what does this look like over 20 years for you? And sometimes the solution you've been offered is actually a great one, even if it is a drug, even if it is the pill. But you need someone to help you strategize
You need
so that
context.
you understand the big picture of
Right.
like, this is what you do now. We work on your pelvic pain while you're on the pill so that when you come off of it, you're not debilitated and taking a week off work every month, right?
Yeah, no, it's so true. I think I told you I wrote a book which hasn't coming out till March, but one of the parts of the book talks about medication, and I'm very clear that women can't they need a practitioner to help with the medication. But I feel like at least if I lay it out for them so they have the scope of what they could use, what might work, you go into a practitioner with a very different attitude. Like, can you talk to me about X? I've heard about X. And if you don't know about X, maybe we can look at it together, That's
Mm-hmm.
very different than going in and like being like, tell me.
That's right. Yeah. Like we want women to feel like a bit more autonomous in their healthcare so that they can feel like they're making good decisions. But you can only do that if you've been given all of the options, if we have a value-based approach to how we answer those questions for you, right? And understanding what your actual goals are. Because if your goals are fertility, you might benefit from Lupron cryopreservation of your eggs and frozen embryo transfer, which coming from a naturopath, that sounds like a very conventional strategy, right? But if you understand what the benefits, how to support yourself during all of those therapies, what the risk benefit ratios are, and you have someone who will listen to what your actual value is, which is maybe just to have a baby at all cost, right? Then women can feel a lot more confident about what they're saying yes to,
There's
even if it
somebody
is medication.
somebody just asked the name of the nutrient that.
Oh, I can see that.
Yes.
It's resveratrol.
Okay. I'm not gonna even try to
Yeah,
say it. But anyway.
resveratrol. And it was only the studies are in a capsule, so you don't have to worry about your blueberry intake. Blueberries are very positive for pelvic pain and endo. It's the nutrient as a supplement is that interacts with Lupron.
So do you, I think I know the answer to this because I'm sort of feeding this to you, but like you have courses that you give online on this stuff, right? Because we have to end in a minute and I know a lot of people are really interested in more information.
Yeah, yeah, we do. So we have a women's health group that we run with our clinic that's a 10-month collective of women that we walk them through a sort of a curriculum or semester of work on learning about women's health and how to support their menstrual cycle, thyroid, metabolism, and whatnot. And so we open enrollment for that a couple of times a year.
And that's for
Um,
anybody anywhere. That is
yeah,
not
we've
just
got women in the
Ontario.
US. We have women in the US. So I've said the limitation is that our meetings are at 7 p.m. Eastern Standard Time. So for some women, we had some women in New Zealand who wanted to join, and they were like, "Oh, we don't think we can make it work with our work because it's in the middle of their work day." So that's maybe the only limitation is that it's run at 7 p.m. Eastern Standard Time. But we have women from the US and from New York who are in our group who joined in the fall. So that's a great way to connect with myself and the other doctors at my office to get that sort of like learning based approach to women's health, which is it's a beautiful 10-month curriculum that we walk women through. And we're working on some individual courses for women that are condition specific. So whether you have endometriosis or PCOS, the best way to stay in touch is just through Instagram, because when all of those things get released, you would be the first to know as being part of that group. And we do have some freebie downloads that some fertility checklist stuff and questions about menopause and how to support that aspect or that transition in your life. We've got lots of free downloads on our through my Instagram if you want to hop in there.
So where do people find you?
So it's at Dr. Jordan ND, would be is my Instagram handle.
And I'm just gonna say again, you're gonna love it because she's so funny. Like it's so I have to tell you, I feel like you have this duo because when you talk, you're very serious and so
Very.
informative and smart. But your posts are so funny. Like they literally are laugh out loud funny. So I love that.
I say come for the memes, stay for the facts. because that's my other goal, is to normalize this sort of like female, hormone experience for women, right? And to know that like there is a real human being behind that account. And so I do all my own social media. I insist on doing it myself because I love it. Like it's a really wonderful way to interact with a huge number of women, which I love. But it also, I think it's important that you can see that there's a real human being who burns her dinner and, whatever, right? Like there's a relatable aspect to it because
Who drinks a lot of coffee, at least
who
according to
drinks a
your post.
lot of
Uh,
coffee.
we
Yeah,
got to
who
talk
drinks.
about that, Jordan. Not so good for you. Um, Listen, we're gonna end. This was so great. I really hope that you will come back again.
I'd love to.
I feel like, I feel like we're really experts, as I said, at the vagina, at the pelvic floor, the muscles. Then we sort of enter the cervix, and you just have so much to share and so brilliantly done. So I was stalking Jordan for a long time. Like it's embarrassing a little bit, but I was stalking Jordan and I was like, maybe you'll come on live with me because I think my followers really love it. Anyways, I just want to say thank you so much because I know you're
Oh, I
incredible.
love it. Yeah, and I've made so many great like practitioner Instagram friends. Like it's actually a wonderful way to connect with. I've met gynecologists through Instagram who are wonderful and are very specialized. I find it such a great way to connect. I've worked with women who are in Australia and New Zealand who are practitioners that specialize in various areas of women's health. That it creates this like global community, which is so cool.
It is
So I
amazing.
love it.
It's amazing. And somebody just said that she's been on her endo journey for many years and she still learned so much information tonight. It was amazing. And I agree.
Awesome.
So thank you so much. And I can't wait to have you back. I'm going to blow a
Awesome. Well,
kiss.
have a great
Okay.
night.
Good night. I'm trying to end the live. There we go.